An arrow only be shot by pulling it backward. So, when life is dragging you back with difficulties, it means that it's going to launch you into something great. So just focus and keep aiming. A very good morning, everyone. I'm Hashini Jayaraman, final year student from Nandha College of Physiotherapy. On behalf of orthopedic department faculties and other department faculties and students from Nandha College of Physiotherapy, we humbly welcome you all for today's webinar, Challenges in Cancer Cachexia by Dr. J. Krishnan sir, PhD scholar, physiotherapist, Chikma, Puducherry. We welcome you, sir. Now, I call Dr. P. Sarandas sir, Professor, Department of Orthopedics, Nandha College of Physiotherapy, to welcome today's webinar.
Thank you. Good morning, all. It's my great pleasure to welcome you all. First, I welcome our resource person and most renowned person in our physiotherapy field, Dr. Krishnan sir, physiotherapist, JIPMAR, Puducherry. Next, I welcome our beloved principal, Dr. V. Manivannan sir, who began all our success and support and enrich our student to get a new knowledge from different person. Next, I welcome our vice principal and all HODs and staffs from Nandha College of Physiotherapy. Finally, I welcome all the participants from various places. Thank you. Welcome you all.
Thank you, sir. Next, I would like to take this minute to welcome our honorable person, Dr. V. Manivannan sir, Principal, Nandha College of Physiotherapy, to share a few words.
Respected resource persons of today's webinar, Dr. J. Krishnan sir, physiotherapist, JIPMAR, Puducherry. Organizers of today's webinar, Dr. Sarandas sir, Saranya Devi ma'am, Kalaivani madam, and Priya madam of Ortho department, all HODs, faculties, participants from various places, and my dear students. Warm good morning to one and all. Once again, it gives me an immense pleasure welcome Dr. Motivational sir for presenting today's webinar on challenges in cancer cachexia. Happy to share. Today is very special day and wish you many more happy returns of the day, sir. Today is Dr. Motivational sir's birthday. Happy birthday, dear sir.
Thank you. Thank you a lot.
Our resource person long way associated with Nandha College of Physiotherapy. I just remember he was the first resource person of our college in our first alumni meet held at 2014 and also one of the chief guests of our first national conference, Physiogala 2016. That was a very really memorable day, sir. He always well-wisher of our myself and Nandha College of Physiotherapy. Thank you very much, dear sir, for accepting our invitation to present today's webinar and spend your valuable time and knowledge with us on your special day. I appreciate the organizers, Saranraj sir and team for organizing this wonderful webinar. Thank you one and all for this wonderful opportunity. Have a great day.
Take over the session. Thank you.
Shall I start sharing the presentation?
Yes.
Yeah, just. Yeah, so let me just, can you view it? Can you view my screen?
Yes, sir.
I get it, sir. We got it. Sorry. First of all, let me thank the organizers for inviting me for such a wonderful event. For the purpose of practicality, like I am switching off my video temporarily for one reason, because my audio quality will be of better perception level. I think everybody is with me. Already online, lots of drawbacks are there, like you cannot have a contact and you don't have the real touch of communication. But nevertheless, at least Nandha College is taking such a good initiative to reach you all. And Nandha College is and I owe a publication to you, into your institution. Maybe this year or next year, beginning, I'll achieve that. Saying these words, I'll switch off my video and let us start the presentation. Yeah. Okay. Can you all visualize the screen?
Yes, sir.
Yeah. Okay. So shall we start straight away, sir?
Yes, sir.
Shall
Sure.
we start, sir?
Yes, sir. Sure, sir.
So, today's topic is challenges in cancer cachexia. It's my routine. I thank my teachers, students, patients, and my special thanks to Nandha College of Physiotherapy, Manivandan and team. Sir, thank you. Thanks a lot. You made my day very special. And thanks all the participants. Okay. Today's topic is not very, very interesting. It's one of the boring topics. Lots of physiology. Don't worry, I'm very bad in that. So I'm not going to get into the depth of physiology, whereas I'll be talking about the practical implications of cachexia. Before getting into the topic in depth, let us try to see what is cachexia all about. Cachexia is something bad. If you want to really remember what it is about, you can just think that's the worst thing can happen, and it should not happen for your enemy also. Okay, so it's a syndromic stuff, like where you have a list of issues usually you find in a terminal patient, and in which you have predominantly You have lots of muscle wastings, and the patient gets thinned out, he loses weight drastically, he's low psychologically, and he's secluded, and things like that. And this cachexia has got a huge impact on the patients. Actually, cachexia is a generalized term. It means those patients who are terminally ill are likely to experience this muscle wastings and weakness and so on and so on. Today's topic, we are going to get into the depth of what is all about in cancer cachexia. So cancer cachexia as such, it is very common in any cancer patients, especially in the terminal part of the disease. So invariably, a patient of cancer is likely to land up with this condition. So hence, cancer cachexia is of high therapeutic value, and that's why we are going to talk about that particular issue today and discuss the practical implications. Hope my audio is clear and the screen is well shared.
Yes, sir. Clear, sir.
Yeah. So what happens? A patient gets cancer. You know what happens. Everybody knows for that fact. There is a tumor arising from a point, and from there which you have a metastasis getting deposited to the vulnerable areas, predominantly the lungs and so on and so on. And depending upon the stage of the disease and the intervention carried out, the patient is likely to make a progress or the survival rate is increased. This cancer cachexia poses a major threat to almost all the cancer patients, and it has got an increased risk of treatment failure. Suppose you take a treatment for cancer and you are in the cachexic stage. The treatment what you are being given will not respond. You will not respond to the treatment, basically. So that's the bad thing about cachexia. And everybody knows a cancer treatment will have lots and lots of side effects. And these side effects will sit on the top of your head and it will spoil every possible thing when you have cachexia, and that is going to cause you innumerable complications. And cancer cachexia is one of the major cause for mortality rate in cancer, and not just the disease or the tumor or the place in which or the manifestation it produces. And because of which you have decreased quality of life and physical performance. That's why physiotherapists come into play in cancer cachexia. And physical performance is a very important marker for prognostic importance in cancer treatment. And because of which you have a huge psychological impact on the patient, on the caregivers, on the society and the family. How do you define cancer cachexia? It's a multifactorial syndrome where you have a huge muscle wastings, which can involve the fat tissues, which may not also involve. And it is likely, it is usually said, it is not reversible, and it cannot be reversed even with the best of nutritional support, and it progressively leads to a impairment stage where the patient cannot be reverted. So that's the gross definition. And if you can see the reference highlighted below, it's by Ferron. They have come to a consensus regarding the definition of cancer cachexia, and it's a complete details about how it goes and how it prevails and how it causes the impact. And before getting into the practical implications and the difficulties and the challenges what physiotherapists face, one should know what are the stages of cachexia. Cachexia as such, it has got a pre-cachexic stage, the actual cachexic, and the refractory cachexia. And you can note the references, these cited from Ferron, and a few slides that will keep going on, and it's worth reading this as far as cachexia. This is a very important slide. Why? Because it really defines and delineates and marks the differentiation between the stages of cachexia. Because once you want to really have an intervention done, get into the practical implications, you need to know the stage. Only then you can really have a say on what really you want to do. So predominantly, the stages are being classified based on the loss of weight. Suppose you have less than 5% of weight loss, you come under pre-cachexic. And if it is more than, you are in exactly on the cachexic stage. And in pre-cachexic stage, you have the stage of you have loss of taste, smell, and you have lot of metabolic changes happening in the body. It starts to initiate actually. You really cannot make out the actual situation or the scenario what the cachexia can predispose. So it has a major say of the changes whatever is happening inside, and the weight loss is very subtle to the extent of just less than 5%. And if that crosses more than 5%, and the predominant weight loss, and you see the marked reduction in food intake with marked systemic inflammation with a biomarker, then it's at cachexic stage. And from there on, you have variable degrees of cachexia. Why? Because you can see there is no specification about the BMI or any other exact marks, because this particular refractory cachexia changes with the type of cancer what you actually present. So very type of cancer is happening, and because of which the definitive I should say the benchmark cannot be created because of the variable presentation and the comorbidities presented with the primary tumor or the metastasis presented with. So this delineation between these three stages has to be clear cut as far as the physiotherapy intervention is concerned. Having said about the stages, you need to know what really happens in cancer cachexia. Please excuse me. This stage is going to be damn boring. But you have to just touch and go and see what is actually happening in cancer cachexia. The systemic inflammation, which is initiated by the primary tumor factors, can have a host tumor reaction. Actually, you have a host getting the tumor, which is implanted in a part of the body, and the host, that is our human body, starts to produce a reaction, and that the predominant response is basically from the cytokine production from the white blood cells. That is the defense mechanism the body reacts, and this is what you call it as the tumor host reaction. That is the primary pathophysiology involved in cancer cachexia. And then what happens from there on? There is something called as it primarily involves three major systems of the human body. As you all know, the primary organ which it has a huge impact is the liver, followed by the skeletal muscle and the adipose tissue, and nevertheless the third organ is the brain, which gets a huge impact because of the cytokine production. That is, the pro-inflammatory cytokines actually has an impact on these three major structures. And we all sit and we are sitting and discussing about this kind of stuff. So just because you have the skeletal muscles getting involved, and that is where our role really comes into play. And what really happens from these pro-inflammatory cytokines, it directly has an effect on the first. When we see about the liver, it starts to produce APPR, that is called as acute phase protein release, and this causes huge amount of impact on the renal system. And what happens is the tumor factor, the necrosis factor, tends to create overload on the renal systems, and it has got a huge impact on the excretory part of because of the tumor factor. And coming to the skeletal, it has got a catabolic effect of the skeletal muscle protein synthesis and the degradation. And there is a literal imbalance between the protein synthesis and proteolysis. Actually, you all know the muscles. Actually, the basic framework of the muscle is the protein, whatever protein you find it in the skeletal muscle, makes up the muscle bulk or the muscle content as such. And the contractility and the stretchability of the basic physiological properties of the muscle is being maintained with the neural connectivity. Nevertheless, the protein makeup of the skeletal muscle makes it the entire structure Without getting into the depth of it, let me go to the next slide. Based on this, you have a management algorithm. I'm sorry for the slide, I couldn't squeeze that tabular column. If you can download this article, it clearly gives what has to be done at what stage. And if you can see the right last, that is the refractory cachexia, you have all palliative care, where it comes more of a psychosocial support to the family and to the caregiver. And every ethical part of it comes to the concern, and it is a survival which matters. So it is highly variable, and really you cannot have a say in that refractory cachexia. Nevertheless, you can intervene to make a difference in the quality of life of the individual. And when it is coming to the pre-cachexic stage, you have to monitor, evaluate thoroughly. As I rightly mentioned, you have the organs, like for example, I said the brain, the liver, the skeletal muscles. So you need to evaluate the biomarkers. Biomarkers are nothing but the anorexic levels, the digestive status, excretory status, and if you're going to see the biomarker of the liver, you can see the IL-6 markers, biochemical values, and all these things are going to be the major biomarkers with which you evaluate the patient thoroughly. This is where the timely intervention comes into play, because you know that this patient is going to get into this cachexia stage. So you start measuring the basic biomarkers. And from there on, you start working on it practically, and you see the progress and try to adjust the dosage. Let it be nutritional support or exercise intervention. You need to adjust based on the evaluation. So evaluation plays a very important role in pre-cachexic stage, and based on which it needless to say that body weight and the BMI calculation plays a major crucial role in evaluating and adjusting your treatment dosage. And in cachexic stage, you have to observe very carefully. Please, gentlemen, just understand, in cachexia, it is not a one-man role. It is completely a teamwork where it starts from the oncologist and down to what not to say. You have to involve even the caregivers, the family, the society, and everything. So it is just a teamwork, and never call yourself primary role player. It is a multi-modal approach where you have everything comes into play. It will start from pharmacological intervention, physical intervention, supplement, psychological support, social support, occupational support, society support. Everything comes into play. And if you see that in approach to a cachexic individual, any one of these factors goes back, then really the patient will feel that impact. So it is a completely teamwork. So I just want young budding physios to understand, in cancer cachexia, not only in cancer cachexia, and almost all the treatment interventions of non-communicable disease, physiotherapist plays a crucial role, but it is definitely a teamwork, and you cannot lift your collar for the success. You have to play a supplement role, and you need to have a teamwork done. So just start making good friends with your oncologists, physicians, and dietitians, and social workers, and so on, to have a good impact on the individual. So having said that, coming to the topic, does exercise therapy, does it have an impact on cancer cachexia? So cancer cachexia is the most, I should say, the remote area where even any part of intervention, let it be pharmacology, let it be nutritional support, whatever it is, it has got plenty of opportunities. In today's presentation, if you would like to carry home some message, you don't like to follow it, or you didn't understand anything, or I wasn't clear, I was incomplete, just understand one thing. Cachexia is one area in oncology where you have tremendous amount of opportunities waiting for you. Let it be starting from evaluation, let it be intervention or follow-up or intervention, whatever it is, you have plenty of opportunity waiting for you. So if you try to catch up with good, like-minded professionals, I think you have a paper next year. And not just looking for a paper, but to standardize your field, your profession, and nevertheless, the human race will have quality of life. Yeah. Now I would love to hear from some students, final years or from interns of PG. One of the students would I would like to ask them, ஒரு cancer patient உங்ககிட்ட வந்ததுன்னா, what will you ask them or what will you tell them before you start intervening? Like for example, ஷோல்டர் பேஷண்ட் வந்து நான் இப்போ டயத்தர்மி கொடுக்க போறேன், நான் இப்போ எக்ஸசைஸ் கொடுக்க போறேன், எக்ஸசைஸ் பண்ணதுக்கு அப்புறம் உங்களுக்கு மூவ்மெண்ட் இம்ப்ரூவ்மெண்ட் இருக்கும், டயத்தர்மி கொடுத்தா வலி குறையும், ஒரு பிஏ ஷோல்டருக்கு நீங்க இந்த மாதிரி சொல்வீங்க. யூ கெட் அ கேன்சர் பேஷண்ட். வாட் வில் பி யோர் health education or what will you explain to the patient before you start working on him or her? Anyone I would like to hear from, please. I know Nandha College is bright and people are highly energetic. I carry loads and loads of energy once I visit your institution. Anybody please. Tamil la பேசலாம், ஒன்னும் பிரச்சனை இல்லை. தமிழ் தாராளமா பேசலாம். Sir, do you hear me? Am I audible?
Yes sir, audible sir.
Hello. Yeah. யாராவது ஒருத்தர் இப்ப கேன்சர் பேஷண்ட் ட்ரீட்மெண்ட் எடுத்துட்டாங்க, கன்ஃபார்ம் ஆயிடுச்சு, நெக்ஸ்ட் வீக்ல இருந்து கீமோதெரபி ஸ்டார்ட் பண்றாங்க, இல்ல ரேடியோ தெரப்பி போக ஆரம்பிக்கிறாங்க. உங்களுக்கு வந்து பேஷண்ட்டை உட்கார வச்சு உங்க முன்னாடி உட்கார வச்சு என்ன சொல்லுவீங்கன்னு யாராவது ஒரு ஸ்டூடெண்ட், ஒரு பாய் ஆர் கேர்ள் ஸ்டூடெண்ட் பேசினா நல்லா இருக்குமே ப்ளீஸ். Nobody? Anybody? Okay. Anybody, sir? Anybody is posting the questions in the group? Okay, fine. Nani சொல்றேன். When I started my practice, in the musculoskeletal practice, at the most பார்த்தீங்க அப்படின்னா பேஷண்ட்டை பார்த்து நான் எக்ஸசைஸ் கொடுக்க போறேன், அது பண்ண போறேன், இது பண்ண போறேன், வலி குறையும், உங்களுக்கு அது ஆகும், இது ஆகும், யூ ஆர் கோயிங் டு இம்ப்ரூவ், ஒன்றும் பயப்படாதீங்க, தைரியமா இருங்க. So this is going to be my word of explanation. But what happens in cancer? That's not the case. Patient உட்கார வச்சு நீங்க பேசும்போது you are going to say, நான் உங்களுக்கு எக்ஸசைஸ் சொல்லி கொடுக்க போறேன். So you will be talking about the negative side of an exercise impact. Okay? Negative side. நான் எக்ஸசைஸ் பண்ணும் பொழுது உங்களுக்கு மூச்சு வாங்கலாம், படபடப்பு வரலாம், வேர்த்து கொட்டலாம். You are going to talk on the negative side of the negative exercise intervention. And at last, what is he going to ask you? Sir, இந்த எக்ஸசைஸ் பண்ணா என்ன வரப்போகுது? கேன்சர் சரியாயிடுமா, குணமாயிடுமா, நான் நல்லா ஆயிடுவேனா? What is going to be your reply? That's a really embarrassing situation for a physio to talk to the individual. Prepare yourself mentally. Make yourself strong to communicate to the patient. Your intervention is going to make a difference in the quality of life. Nothing more and nothing less. But this statement, what you're going to make, has to be in accordance, in concurrence with your boss. That is your oncologist, physician. And you have to have a same say when you're going to start the intervention. That's where the teamwork comes into play. That's when the physician, the physiotherapist, the nutritionist, the pharmacologist, everybody sits and talks. Everybody is there and the boss starts. Sir, நீங்க எக்ஸசைஸ் பண்ணணும். உடனே அவன் கேட்பான், எக்ஸசைஸ் பண்ண என்ன ஆகும்? சரியாயிடுமா, கேன்சர் கட்டி குறைஞ்சிடுமா? That's going to be easy. நம்மளே இருந்தாலும் அந்த கேள்விதான் கேட்பேன். You are going to explain it very carefully, sir. இல்ல, that is not going to happen. We hope that will happen. But நம்ம பார்க்கறது வந்து quality of life. Blah 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 blah. இதெல்லாம் எதிர்பார்க்கணும். Blah 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 blah. இதெல்லாம் நடக்கும். இதெல்லாம் நடக்கக்கூடாம இருக்கிறதுக்கு we are going to do. So you are going to explain the complication and you are going to caution him. Second thing, you are going to say that you have to do it cautiously. The way to do it. See, all these things accounts on the negative side. That's the most critical and the crucial role for a physio to communicate to a patient. So, ladies and gentlemen, that's not an easy stuff. You have to stay strong and communicate to the patient and get it done. If you fail in this, the complete program is doomed. So, communication is a skill, and communication plays a very important role in cancer cachexia as far as physiotherapy is concerned. So, having said that, what really happens in cancer cachexia as far as exercise intervention is concerned? It causes a lot of impact on the skeletal muscle, adipose tissue, liver tissues, and on the brain. It has got a multiple area of target, and it has got multiple effects. And predominantly, it causes inflammation. So inflammation, exercise has been found to be an anti-inflammatory effect. In the pro-cytokines in the tumor cells produced, that has got an impact on the host in our body. Our body body inflammatory cells direct tumor cells indirect blood vessels மூலியமா. So இதை negative அதாவது அந்த inflammation control பண்றதுக்கும் anti-inflammatory effect பண்றதுக்கும் you have the exercise concept which it comes into. This particular platform would be too heavy for me to explain what are the basic theories which are concerned for anti-inflammatory effect. With that, I stopped that anti-inflammatory effect of exercise therapy. And muscle atrophy, that is the primary target for physios as far as cachexia is concerned, and for which you are going to intervene in the form of aerobics and resisted exercise. So that is going to take care of the atrophy part of it. And very important, tumoral progression. Exercise is found to reduce the tumoral progression. What is a cancer treatment? What is the intervention of oncologist? He is going to suppress the cancer growth. The tumor growing is going to trying to put it down. Is going to reduce the rate of inflammation, the rate of growth of the cancer tumor cells. Okay, is going to be it is going to be stopped, or it is going to be harnessed by the oncological intervention. Exercise is also a medicine where you are trying to suppress the tumor growth. That is where our role becomes even more important and attractive, and I should accept the fact, lucrative as well. And last but not the least, gentlemen, I believe strongly in this survival. Exercises are set to produce and is going to make a huge impact on the quality of life of cancer patients, and it is going to improve their survival rates. What is palliative care is all about? Is to give you a good quality of life till you survive. In that scenario, your survival is going to be improved with exercise, and that has been proved time and again. So exercise therapy is not just going to improve your range of motion or reduce pain. It is going to improve your survival. That's something remarkable which you should be proud of. And survival rate is said to be improved with exercises, and a lot of studies supports. They're just coming out of ரொம்ப மேலோட்டமா இந்த எக்ஸசைஸ் இன்டர்வென்ஷன் நான் பேசுறேன். Effect of is on cachexia, but we are going to see the challenges what you really face in cancer. Having said this, I just think about it. I'm sorry for the size of the slide. I could not make it more clear. This is a guideline from ACS, American College of Sports Medicine, which they say the dosage of exercise intervention in cancer. If any intervention as far as aerobic concern or anaerobic resisted exercise is concerned, you need to have a dosage. If it is an aerobic or resisted or both, you need to have a specific dosage. Even the particular intensity it is thrice a week for 30 minutes of moderate intensity if it is aerobic, twice a week 2 sets of 12 to 5 repetitions for the important muscle groups again of moderate intensity. If it is a combination, you can have thrice a week 30 minutes per session, and with a combination of the earlier described stuff. So this is one thing which has got a guidelines. You should understand, I could not get a guideline, standard guideline. For all these days which I have been searching, I could find people coming up with some sort of a guideline according to their own experience, a level 4 evidence. They start to follow and they advise us to follow us also. This is only one thing which is based on strong evidence that this amount of dosage and duration and intensity can make a difference in cancer-related fatigue. This is called this can have a good amount of outcome based on latest evidences, and this is a guideline which has been released by ACSM. Coming to the important slide of today's, the very important slide. Why it carries importance? No, we call it a vertical because this gentleman, way back in 1944, Rush, now you can see he has got huge citation because he was the first one to highlight. He picked up albino rats. What he did was he just gave some cancer-producing cells on this, and he observed the tumor growth for a stipulated time frame, and we observed that those rats, control group, experimental groups, they experimented them, and they saw that the aerobic exercises had a huge impact on the tumor progression. They found that in the experimental group, where the rats were subjected to aerobic exercise for a stipulated time, they had shown the less tumor growth, and that gave a strong signal. And from there on, they started working on exercises on tumoral growth suppression. So, ladies and gentlemen, please feel proud of our Rush paper. That was the first of its kind, which gave way for future researchers to follow upon. And intensity is a very important thing which you can. சில சமயங்களில் நம்ம என்ன பண்ணுவோம்னா ரொம்ப பண்ணிடுவோம். ஓகே, ரொம்ப பண்ணும்போது you land up with complications. பயந்துகிட்டே ரொம்ப கம்மியா பண்ணுவோம். You land up with nil outcome. அப்ப என்ன ஆயிடுன்னு கேட்டீங்கன்னா, you lose the patient confidence or you lose confidence from the physician. He will understand that we don't know about the intervention part. We are not skilled. It's not actually so. Skill irundalum, the dosage part plays important. This particular paper from Sloan, way back in 1985, have given a trial on tumor necrosis factor protection under a conditioned in vivo study. அவங்க என்ன பண்ணிருக்காங்க அப்படின்னா, they have tried to produce the effect of TNF in cells in the plasma. அவங்க என்ன பண்ணிருக்காங்கன்னா, high intensity training, moderate intensity training கொடுத்திருக்காங்க. அவங்களுக்கு என்ன பார்த்திருக்காங்க அப்படின்னா, இந்த சைட்டோகின் ப்ரொடக்ஷனோட, இந்த சைட்டோகினோட வேரியபிலிட்டி வந்து இந்த மாடரேட் எக்ஸசைஸை விட ஹை இன்டென்சிட்டில வந்து நல்ல வந்து நோட்டபிள் சேஞ்சஸ் வந்திருக்கு அப்படின்னு காமிச்சிருக்காங்க. ஸோ இமேஜின் போத் ஆஃப் அஸ், நீங்களும் நானும் கொடுக்குறோம், நீங்க மாடரேட் கொடுத்துருக்கீங்க, நான் எடுத்திருக்கேன், ரெண்டு பேரும் ஒரே கண்டிஷன் தான், ஒரே மாதிரி கொடுத்துருக்கோம். பட் we didn't produce the same outcome because of the variance in the dosage. ஸோ நீங்க என்ன புரிஞ்சுக்கணும் அப்படின்னா, dosage is the critical factor in all these non-communicable diseases. அதில் தான் நம்ம நார்மலா ஃபீல் ஆகும். Patients will start losing confidence on the exercise intervention because you are not very sure about the dosage. So calculating the dosage, tailoring to the individual matters a lot. So this one example, they have found that high intensity training gives a good impact on TNF production in humans, and way back in 1985. Coming to the core of the topic, we have risks. Exercise la risk illamal illai. Musculoskeletal practice, suppose shoulder fracture, shoulder stiffness, elbow, and அதுல வந்து வரும்போது at the most risk வந்து பாத்தீங்கன்னா pain reproduction or flaring up of symptoms. பெயினால வர்றவங்க பெயின் அதிகமாகும், ஃப்ராக்சர் ரெக்கவரியில வர்றவங்க ரீஃப்ராக்சர் ஆகும். because this is not life threatening. ஆகலாம் நான் சொல்ல வரல, ஆகணும்னு சொல்ல வரல, ஆகலாம் ஒரு ப்ராபபிலிட்டி. இத்தனை பட்சத்துல இந்த கேஸ்ல வந்து நீங்க ரிஸ்க் பாத்தீங்க அப்படின்னா, there is always a risk involved in exercise intervention. பட் என்ன சொல்றாங்க அப்படின்னா, எப்பவுமே வந்து எக்ஸசைஸ் இன்டர்வென்ஷனோட அவுட்கம் வந்து it outweighs the risk factor, provided it is being carefully administered, tailored to the individual to the required levels. So, அதனால என்ன சொல்றாங்கன்னா அந்த moderate intensity intervention to start with is always warranted. So, there is risk in exercise intervention that will cancel. It is life-threatening. You can have serious complications. You have to be very careful in selecting the exercise intensity. Okay, if any evidence you can part, I think next week or next month or whenever you have time, just download this paper, wonderful paper. இவங்க என்ன பண்ணிருக்காங்கன்னா எக்ஸசைஸ் இஸ் மெடிசன் அவங்க என்ன சொல்லுங்க EIM அப்படின்னு போட்டிருக்காங்க. இந்த பேப்பர்ல வந்து they have analyzed in depth எதுக்கெல்லாம் எவிடன்ஸ் இருக்கு எப்படி பண்ணலாம் அப்படின்னு. நீங்க பாத்தீங்கன்னா லெஃப்ட் ஹேண்ட் சைட்ல ஆஃப் யுவர் ஸ்கிரீன் யூ ஹேவ் ஸ்ட்ராங் எவிடன்ஸ் ஃபார் தீஸ் 6 or 7 headings. You've got moderate evidence on sleep and bone health, and you don't have evidence for cardiac toxicity, chemotherapy-induced peripheral neuropathy, cognitive function, falls, nausea, pain, sexual function, and treatment tolerance. What importance does this slide play today? Those individuals who are looking for an avenue of research in oncology, this is going to be a wonderful slide. You can work on the right extreme of the tabular column. Just get into the review of literature. You can have plenty of avenues, provided you have a platform. You will excel. And please understand, oncology papers are most quantitative. Let it be whatever it is. Oh, this is what seriously we people are. I do this, I do that. Teamwork. Ladies and gentlemen, this paper discusses what oncology is seriously lagging. ஒரு ஆன்காலஜி பேஷண்ட் கிட்ட ஆன்காலஜி சொல்லப்பட்ட ஒரு கேன்சர் பேஷண்ட் கிட்ட போயிட்டு நீங்க போய் கேட்டீங்கன்னா அவன் கேட்பான், ஃபர்ஸ்ட் கேட்பான், யாருக்கிட்ட போய், எங்க போய், என்ன பண்ண போறேன், எப்படி பண்ண போறேன், எவ்வளவு பண்ண போறேன். He doesn't have a clear picture at all because nobody explains him. What is the real act now? What is the problem அப்படின்னு பாத்தீங்க அப்படின்னா we don't have a clear cut precise rules. யார் என்ன பண்ணுவா அப்படிங்கிறதுல வந்து டீலிமினேஷன் நம்ம கிட்ட கிடையாது. எக்ஸசைஸ் தெரப்பி பத்தி பிசியோதெரபிஸ்ட், நியூட்ரிஷனை பத்தி நியூட்ரிஷனிஸ்ட் will not talk more about exercises. Physiotherapist will not talk about the nutrition. Should not talk about nutrition. He can say consultant nutrition, take a word from him. We should not say anything about that. So there has to be correct delineation, a correct role play, responsibility, delivery, and follow and support. Continuum support. So this paper highlights about how teamwork really matters to the patient. Believe me, it is not for the oncologist or not for the physiotherapist or for the nutritional supplement therapist. It is for the patient. It is patient-centered work, and teamwork is very, very crucial and important. Continuing to that, what really they found out in this paper? What was the research question? They wanted to see what is a real problem an oncology physician or the therapist or the patient or the caregiver really experienced. How they could narrow down is that they started getting the data from the patients. Huge volume of patients were collected, in which 95% of them felt exercise is important. So they have been explained clearly. Almost 100%, all of them have understood exercise is important. Okay, done. ஒரு வேலை முடிஞ்சு. அடுத்ததா பாத்தீங்கன்னா இதுல 80%, 100ல 80 பேர் வந்து ஹோம் பேஸ்ட் எக்ஸசைஸ் தான் ப்ரிஃபர் பண்றாங்க. They don't prefer to come to a clinical setup. ஒரு லேபுக்கோ, ஒரு ஜிம்முக்கோ, ஒரு ஹாஸ்பிட்டலுக்கோ, ஒரு கிளினிக்கோ அவங்க வர்றதுக்கு பிரியப்படலை. அவங்க பிரியப்பட்டது எல்லாமே ஹோம் பேஸ்ட் எக்ஸசைஸ் தான் அவங்க ப்ரிஃபர் பண்ணியிருக்காங்க. அண்ட் பாதிக்கு பாதி பேர் வந்து 50% ஆஃப் தேம் என்ன சொன்னாங்கன்னா எங்களால எக்ஸசைஸ் பண்ண முடியாத காரணம் வந்து ஃபெட்டிக். இது வந்து ஃபெட்டிக் வந்து பாத்தீங்கன்னா கேன்சர் ரிலேட்டட் ஃபெட்டிக் அப்படிம்பாங்க, CRF, which is a very important and a very, very common complication of our chemotherapy or radiotherapy or whatever intervention oncologists give to the patient. So based on that, என்ன பண்ணிருக்காங்க அப்படின்னா this they found out to be a predominant barrier for exercise intervention. And இதுல பாதிக்கு மேல பாத்தீங்கன்னா எங்களுக்கு வந்து ரெஃபரல் சிஸ்டம் மூலியமா எக்ஸசைஸ் வேணும் அப்படின்னு கேட்குறாங்க. பிகாஸ் இன் வெஸ்டர்ன் பார்ட் ஆஃப் த கண்ட்ரி, this paper is from UK, they said until you have reference, you will not come into play. If a physician doesn't refer you, the patient will not come to you because you will be paid from a system and not from the patient. So they preferred a referral system for exercise intervention. Not only in UK, in our country, Asian countries also, this is a serious lacuna. The referral system is not very clear. The therapist doesn't know when to intervene, how to intervene, how much to intervene. And the referring physician also is and carry it forward. And the last constraint and the last barrier, what they said was the time constraint. And I'm sorry to say, lack of expertise in making exercise recommendation was cited as a barrier. Let it be a physician or a staff nurse or a nutritionist or a therapist. The lack of expertise was highlighted by the patients in this study. So you could understand, even though 95, almost 100% of the individuals have understood that exercise is important, they could not carry because of these barriers. இந்த மாதிரி ஸ்டடி தான் நம்ம பண்ணணும். நம்ம புதுசா ஒரு இன்டர்வென்ஷனை கொண்டு வந்து அதை சூப்பர்னு சொல்றதை விட ஒரு எக்ஸசைஸ் காம்ப்ளைன்ஸை ஏன் எப்படி இம்ப்ரூவ் பண்ணலாம் அப்படிங்கிறதுல வந்து we should be very very clear in that. So இந்த மாதிரியான ரிசர்ச் கொஸ்டின் வச்சு பண்றது, it would be a wonderful suggestion to go on with the study. What are the undesirable effects usually you see? Usually with cancer cachexia, you can see nausea predominantly, vomiting, neuropathic pain, ரொம்ப common that you have to be prepared. You have to be very much prepared. And the emotional state is highly disturbed with exercises. One day you have pain, the next day you will never turn up for exercises. The emotional state has a crucial role to play, and it's the most unwanted effect of exercises. And commonly everybody will know weakness and fatigue is a common undesirable effect of exercise. So really, having said all the good effect of exercises, the common difficulties what you face with exercises, the challenges what has been highlighted by Leal et al. In the first reference what I cited, it is the prescription and the stage at which you are being referred. So prescription varumbodhu, the predominant thing what comes to your purview is that the expertise what has to be there for a therapist to prescribe exercises to the individual and in which stage he is on. And the same thing holds good for the referral system. That is the physician who has to take a call on exercise intervention on the time, on right time, on right place, the right person. So the intervention, the time of intervention is a crucial role, and the expertise involved in exercise prescription is the main challenge which has been highlighted by Leal et al. In 2021. That's a very recent paper which was published in February this year. And the next challenge was the motivational status and complaints. That it is a patient, shoulder patient, back pain patient, neck pain patient, cancer patient. So that is a quite important and a very, very, I should say, very, very important marker for your therapy outcome is the motivational status and the complaints of the individual. And the third challenge what usually you face in cancer is the if you can list, I'll be happy to listen or to get it from you. What are the controlling parameters or the markers or the variables you can monitor or control on the exercise intensity for cancer patients? Anybody? Like, நான் கேட்குற கொஸ்டின் வந்து என்னன்னா, எதை வச்சு நீங்க வந்து எக்ஸசைஸ் இன்டென்சிட்டியை ஆர் எக்ஸசைஸோட அவுட்கம் மெஷர் பண்றதோ மாடுலேட் பண்றதோ நீங்க வந்து ஒரு ஏரோபிக் எக்ஸசைஸ் ஆகட்டும் ரெசிஸ்ட் எக்ஸசைஸ் ஆகட்டும் யூஸ்வலா என்ன வச்சுப்பீங்க? Hope you are with me. I know it's boring. Okay. This control of training variables நான் எதுக்கு ஹைலைட் பண்ணலாம்? ஒரு உதாரணத்துக்கு எடுத்துக்கிட்டீங்கன்னா BMI அப்படின்னு வச்சுக்கலாம். இந்த BMI ஒரு வேரியபிள். இந்த வேரியபிள் வந்து does have a control on the training module. இதுல வந்து பாத்தீங்கன்னா it comes along with the body weight, the height, and the resistance weight what you are using onto that, that is 1 repetition maximum.
Sir? Sir, not audible, sir.
Are you there?
Yes, sir. Now okay.
Sir.
Sir, screen not visible, sir.
From my end? Sir, if visible?
No, sir, screen not visible.
Ipa, sir? Ipa visible, sir?
Yes, sir.
Yes. So, where did I get lost?
This slide, sir.
Training variables of the basically. Yeah. The side and the control variables வந்து பாத்தீங்கன்னா இந்த repetition maximum ஆகட்டும், BMI and rate of perceived exertion, இதெல்லாம் வந்து கண்ட்ரோல் பண்றது ரொம்ப கஷ்டம் கேன்சர். See, you have to watch his heart rate, you have to watch his performance, the way he is doing it safely or not, the weight with which what he is lifting on, his nutritional status, his hydration status. இது எல்லாத்தையுமே வந்து கண்ட்ரோல் பண்றது கொஞ்சம் பெரிய சேலஞ்ச். ஸோ ஒரு 2-3 பேரை வச்சு பாக்குறது இல்லாம ஒரு பேஷண்ட் வந்தாங்கன்னா வந்ததுல இருந்து முடிச்சுட்டு போய் திருப்பி அவங்க அனுப்புற வரைக்கும் you have to have it has to be highly individualized. So that's the biggest threat. எங்க மாதிரி செட்டப்ல இது ரொம்ப 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 கஷ்டம் because we treat some 10-12 patients all together. அந்த சமயத்துல you are likely to have every sort of complications. நல்ல ஒரு outcome கூட வீணா போறதுக்கான challenges இருக்கு because in the training variables வந்து there are n number of variables starting from your pulmonary, musculoskeletal, cardiac, renal, nutritional, everything will come into play. That is a major threat for a therapist to have a control on. And last but not the least, it's the delayed referrals. சரியான சந்தர்ப்பத்துல சரியான சமயத்துல உங்களுக்கு ரெஃபரன்ஸ் வராத பட்சத்துல உங்களுக்கு சரியான இன்டர்வென்ஷன் கொடுத்தாலும் அதுக்குண்டான எஃபெக்ட் கிடைக்காது. So these are all the major challenges. Let me just summarize because it's the core of the topic. First is the prescription and the stage of the disease. The second, the patient-oriented, that is the motivation status and the complaints. And the control of the training variables. And the last one is the delayed referrals. Prescription and cachexia stage. Prescription nama kudukurom. Okay. Normally, வந்து cachexia வந்து we have n number of interventions. Aerobica, resistance, rendu chenda, illa rendu onnu illam. See, I'm telling you one thing. Now, these following slides, we are going to see these challenges, how it can be handled better. This is just my suggestion based on my little experience. There can be a wider scope or there can be many more materials which I'm not aware of. If it is so, please bring it to my notice. I would love to learn from you. Prescription, you have to be very careful and it all depends on the pre-disease status of the individual. நல்ல அத்லெட்டா இருக்கிறான், திடீர்னு disease வந்துருச்சு, அவனை போய் பார்க்கும்போது it will be much easy for you to handle rather than handling a obese, smoking, alcoholic, 50-year-old male who is obese. So இவங்க 2 பேர் செலக்ட் பண்றதுல வந்து உங்களுக்கு நிறைய வேரியேஷன்ஸ் இருக்கும். So you have to be very, very skilled enough to select the type of intervention. Believe me, aerobic exercise has to do a lot of impact on the systemic inflammation and the disease process. So do you have, how much time I have, sir? Sir, do you have time more or should I rush?
You can continue, sir. So you can continue, sir.
Oh, how much more time is left? Scheduled time?
Sir, not fixed one, sir. You can continue.
Okay. Okay. So aerobic exercise has got an impact which is said to have least cancer-related fatigue. And aerobic condition as such is very good, but you need to have a very good flexibility and strength to carry on these aerobic reconditioning. But the general rule is low and slow approach recommended by ACSM, which says that you go start very less, make the patient educate very well about the unwanted undesirable effects of exercises, and start with a less intensity, duration, and frequency, and go gradually. That is the solution suggested for prescription and cachexia stage. Motivational status and complaints. I have a strong feeling that most of us fail with exercise therapy intervention just because we don't get to see and understand the motivation status of the patient. அதை பத்தி தெரிஞ்சுக்காம நம்ம இன்டர்வென்ஷன் கொடுக்கும்போது எவ்வளவு நல்ல இன்டர்வென்ஷன் கொடுத்தாங்க. So understand the motivational status of the individual, attitude, his complaints, his habits, lifestyle, and then start intervening. And effective therapeutic intervention lies in identifying the right barrier and the appropriate barrier which is preventing the complaints for the exercise intervention. Again, the training variables which I spoke in plenty in that previous slide, you have all these variables which is monitored, and it has to be documented and it progress gradually without causing serious effects to the individual. And you can see they are multi-system. One app
Sir, not audible, sir.
As I said, nutrition, fatigue. Fatigue is very important. You cannot just like that ask a patient and just start asking to do bench press some 10, 20 times without knowing. Biochemical markers. Markers I have not discussed much because it's very, very costly stuff, and you should not do it until otherwise it is deemed necessary. For example, in case of research purpose, for example, IL-6 is a very important biomarker, C-reactive protein, CRP levels, all these are important markers. And again, when you're having a training done, you need to have an eye on HB, hemoglobin level, his nutritional status, hydration status, all these are very, very important, and plasma concentration, his ESR levels has to be continuously monitored. Please don't hesitate to stop if hemoglobin level falls below the prescribed level. So like this, what example I cited, have an eye on the biomarkers, biochemical markers before and after exercises. And I'm not asking you to do it repeatedly, but have an eye before you could really initiate and continue, and have an eye when you really progress on exercise intensity. About the home-based physical activity, and this is very useful in case of cancer survivorship. And this picture says volume. It improves your self-efficacy, fitness, and psychological well-being. Just imagine a lady who suffered a breast cancer. If she's back to her kitchen and can produce a good chicken korambu on Sunday afternoon like this, that is the best thing what she can do for herself and the family. So home-based exercise always has an edge to that of other forms of exercise. And towards the fag end of the presentation, this is a continuing challenge to any oncologist, oncological physiotherapist. Survivorship is the primary and ultimatum care. And this is not just one-man job, as I previously mentioned. That's a shared care model. This article highlights importance of the oncologist, therapist, the teamwork, everything comes into play. So this is not just today or past challenge, it's the challenge forever and for the future. Having said this, the suggested model highlighted by Schmitz et al., the previously cited article in the presentation, there's the EIM, the exercise is medicine in oncology, the 5A approach. The physician starts to ask, advise, agree with the patient, assist him in continuum, arrange for follow-up in continuum. This 5-year approach gives a complete, precise picture, and you can overcome the challenges what a patient faces in cancer cachexia. This gives a complete picture. You see, it is all patient-centered, and it is more oriented towards the patient's family, the caregivers, and so on. So they just come into play for you to have a say in the treatment delivery and treatment care in continuum is concerned, because it's not one day job, it's in continuum. You need to have a large of heart and mind in it, and attitude comes into play, and motivation status, not only for the patient, but for the attendant. So this suggested 5-year approach is a right solution for the challenges what I have just presented. Of course, I have evidence for this. This paper highlights the 5-year approach with which it just compliant with international standards for oncological intervention. And last but not the least, individualization is the key. Every patient is different from the other. And believe me, no, there is no cookbook recipe, and one dress doesn't suit all. So you have to carefully evaluate, identify, tailor the exercise intensity, and you have to keep varying the intensity to the extent that the individual suits and understands and follows. And self-administration is the important thing. And thanks. And you should be like this, to stand beside your patient, to motivate, to mobilize, to carry on further, and to look out for the horizon. And that's how you should live as an example. Even you have a lot of grief, you cannot carry further, and just motivate, support the patient. No, you make a lot of difference. And ladies and gentlemen, just work with one cancer patient, and you will know how beautiful it is. You won't make a big difference, but you make a little difference, but that matters, because it matters the quality of life to a cancer survivor. Believe me, it's not easy. It's not easy. You have to work with a team. Team approach is the one solution for every non-communicable disease, and in very special and specific cancer, it plays a major role. And thanks a lot for this wonderful opportunity. You provided a platform for me to learn, revise for all these 10-15 days. I learned a lot. Thanks, Manivannan, sir, your team, Nandha College, close to my heart. Thank you. Thanks a lot. You made my day. Wonderful birthday for me. Thank you.
Thank you, sir. I request if there is some questions, I request everyone, please kindly ask your doubt in the chat box.
I'm very sure there cannot be such questions.
Thank you, sir. Now, I call Monisha, final year student, Nandha College of Physiotherapy, to deliver the vote of thanks.
Good afternoon, all. Thank you, Arshini. Myself, Monisha, final year BPT, Nandha College of Physiotherapy. I'm here to present the vote of thanks. It is an honor for me to get the opportunity to thank all the dignitaries. I would like to thank our honorable guest, Dr. Mohana Krishnan sir, to take out this time from his busy schedule to grace this event. Thank you for enlightening and encouraging us with your knowledge, sir, on this special day, on this special topic. I'm pretty sure the precious knowledge that you gave us will definitely help us in our studies and future too. I especially thank our principal, Professor V. Manivannan, sir, for providing an immense support to make the webinar as successful. I extend my gratitude to all the HODs and staff to organize the webinar, even amidst the pandemic. Finally, I thank all the participants. Thank you all. Stay safe, stay healthy. Thank you.
Thank you, Monisha. I request everyone kindly fill the feedback form and to receive your e-certificate. Let's wrap up and meet up in another session. Until then, please stay safe and strong. Let's fight together to overcome this pandemic. Thank you, everyone. Have a great day.
Thank you. Thank you. Bye-bye.
Thank you, sir.